Good evening, everyone. My name is Evandro Azambuja, medical oncologist from the Jules Bordet Institute, and it's my pleasure to be here on the studio today with excellent faculty to discuss multidisciplinary perspectives in breast cancer. This faculty, today, we have the presence of different multidisciplinary approach. So we have Dr. Erica Hamilton from United States. She won't be present with us, unfortunately, today, but she participated in all preparation of this meeting. Dr. Stephanie Graff from the USA as well as a medical oncologist. Dr. Roberto Salgado from Belgium, who is a breast pathologist. Dr. Isabel Rubio from Spain, who is a surgical oncologist. Dr. Pierfrancesco Franco from Italy, who is a radiation oncologist. Mrs. Eva Wulf, who is a patient advocate from Germany, and Mrs. Tanja Spanic, who is also a patient advocate from Slovenia. So welcome everyone here into the studio. Welcome to Stephanie and Tanja online. So this webinar today is a hybrid format. So we have people here on the studio, but we also have people online. This meeting was organized by OncoAlert in collaboration with Mirror of Medicine and iScan. And thank you to the sponsorship of Daiichi Sankyo, AstraZeneca, Lilly, and Gilead, you could make this possible. So this should be an interactive webinar. There is a possibility to ask questions. If you look into the right side of your screen, there is a button where you can put your question and you type your question and then you click send. There will be also a voting system that you can also vote either here in the studio or at home. So if you have to vote, there will be a layover on your screen, then you tap your answer and submit. For those here on site, you have to scan the QR code to participate. So I just start off with the first question, that is, which specialty are you attending? So are you a medical oncologist? Are you a clinical oncologist? Are you a radiation oncologist? A surgical oncologist? A gynecologist? Or other specialty? Apologies for not having the pathologist.
That's the other guy.
So please vote now. Okay, so the answers are coming in, and indeed, we have about 29% medical oncologists. We don't have any clinical oncologists at this moment. We have 29% radiation oncologists. We have 20% surgical oncologists, gynecologists 4%, and other specialty 20%. So it's going to be a very interesting and multidisciplinary meeting today. So this is the agenda for today's meeting. I'm going to start with some case presentations, and then you're going to hand over to the other speakers. We're going to have Dr. Stephanie Graff taking over for Erica Hamilton, talking about the current evidence in breast oncology, and also talk about fertility preservation, current controversies in breast oncology. Then you're going to have Dr. Roberto Salgado talk about the pathologist's view. Dr. Isabel Rubio talk about the surgeon's view. Dr. Pierfrancesco Franco talk about the radiation oncologist's view. And then Mrs. Wulf and Spanic talk about the patients and the process of decision-making after the diagnosis. And then afterwards, you're going to have some time for discussion and question and answers. And we also have some clinical cases afterwards. So I'm going to just start with a multidisciplinary clinical case just to highlight the complexity of treating patients with breast cancer today. So this patient, she's a very young patient, she's 32 years old. She presented with a palpable left breast mass, and she had noticed this lump a few months ago, but she thought that it was related to lactation because she had the first child at the age of 30, and she breastfed this child for 18 months. She had no other remarkable disease. She had only 2 surgeries, that was tonsils and wisdom teeth that were removed as a teenager, and no other surgeries. She is married. She has one child that now is 2 years old. She is lifelong non-smoker. She drinks 1 or 2 glasses of wine per week, and she works as assistant bank branch manager. As I mentioned, she has only one child. She had only one pregnancy. She started menses at the age of 11, and she had the first birth at the age of 30. She breastfed for 18 months, and she had used contraceptive for 6 years, but she's not using any contraceptive at this moment. She was planning to have a second pregnancy. So for her family history, she has a paternal grandmother with breast cancer at the age of 55. She has also a paternal first cousin with breast cancer when the patient, the relative was older, but we do not have many details on this cancer. In the physical examination, she had a palpable left breast mass, which was 3 centimeters in the outer quadrant, which is freely mobile. No skin changes, slight flattening of the nipple. In the axilla, there were 2 palpable nodes of 1.5 centimeter. There was no palpable supraclavicular lymph node. She had a biopsy. In this biopsy confirmed an invasive ductal adenocarcinoma, no specific subtype. She had ER 70%, PR 45%, R2 1+, which is considered negative, grade 3, and KI 67, 60%. They also tested TILs, which was 30%. We're going to discuss this later with Roberto as well. She had extensive lymphovascular invasion, and she had extensive high-grade DCIS component. She has a luminal B cancer. So in imaging, she had a mammogram and ultrasound that confirmed a 3 centimeter mass with microcalcification. It was BRADS 5. She had 2 suspicious lymph nodes, one that was completely loss of ectexture, diffuse cortical thickening, and 1 focal nodular cortical thickening of 3 millimeters. She also performed a MRI on the bilateral MRI, but on the left side there was a 4 centimeter mass in race with heterogeneity and a high likelihood of malignancy, and 1 suspicious lymph node in the left axilla. So during this phase, she also was tested for to perform the genetic tests. It was discussed in the multidisciplinary team, and since she is a young patient, she had a luminal breast cancer. It was decided for a new adjuvant approach with chemotherapy, and it was proposed 4 times EC dose dense, followed by 12 weeks of paclitaxel. She went through all treatments. She had no major side effects, and there was no dose reduction required. She performed the breast image after the neoadjuvant treatment and before surgery. In the mammogram, we could not see any mass anymore. There were residual microcalcifications in the tumor area. In the ultrasound, completed radiological response, and the breast MRI, equally completed radiological response. So this patient was operated. She was submitted to a tumorectomy, and they found residual disease, but a near complete remission, RCB1. And the size of the residual disease tumor bed was 3 centimeters, and in this 3 centimeters we had some cancer cells. And there was 1 lymph node that was resected. They had isolated tumor cells. In the 2 other lymph nodes, there was scar tissue. Grade and KI67 was not possible to do anymore because she was in near complete response, but she also had some persistent extensive lymphovascular invasion and DCIS. So my question to you online and here in this studio, which would be the adjuvant systemic therapy for this patient? Would you go for endocrine therapy with tamoxifen? Number 2, would you go for endocrine therapy with tamoxifen plus ovarian function suppression? Number 3, endocrine therapy with ovarian function suppression and aromatase inhibitors. Number 4, endocrine therapy plus abemaciclib for 2 years. Or number 5, endocrine therapy plus olaparib if BRCA1 or 2 germline mutation. So please vote now. The answers are coming. People are a little bit divided, but it's still few response for the moment. Let's see. What do you do in this case, any of you? What do you think?
Well, I think she's a high-risk patient. She's young. She has, she has almost a complete response. She still has some lymphovascular invasion. That means that, there is still tumor there. So I think she will probably benefit from ovarian suppression. And I can choose 2 or 3, tamoxifen or aromatase inhibitors.
Okay, thank you. Just to clarify to people online, the patient is not pregnant, okay? She wants to get a second baby, but she's not pregnant at this moment. So,
yeah, the point is actually how to weight, to me at least, how to weigh the response to the primary systemic therapy, whether we can actually somehow tailor our adjuvant approach based on the response, or whether we should weight more the initial clinical presentation of the patient, meaning the patient characteristic, the tumor characteristic. And so it's a hard question. I wouldn't know exactly how to intensify the adjuvant treatment now, actually, to put my threshold of intensity for the adjuvant treatment. So that's a tricky point. But I would also go for 2 or 3. I'm not sure. I would be tempted to go for 4, option 4, but I wouldn't be sure right now.
Okay. And the pathologist, what do you say about this?
Since I'm a pathologist, it's difficult for me to judge some treatment options. I think the element that I would like to discuss with you and with the audience is how should we interpret the extent of immune cells in this high-risk luminal breast cancer, considering the emerging data that will be presented hopefully later this year of 2 phase 3 trials of neoadjuvant chemoimmunotherapy in the high-risk luminal disease setting. So we have the Keynote 756, of which we only have seen the press release. And there is this other trial, the 7FL from BMS, for which we have not seen data yet. But the press release of Merck showed that you have a significant increase of PCR rate if you combine chemo with immunotherapy in the neoadjuvant setting for the high-risk luminal disease.
Yeah.
So I think one element, if we would do this next year, it will be a 6th option, probably.
Probably, but now the patient was treated, so we cannot use the immune checkpoint inhibitor yet.
I think is also important is how the patient feels. Like, is she a person that is more like on the safety side, so she would rather do more than less? Or is she like relaxed and she would say, you know what, I don't want to take the maximum and more. It's okay for me to have a good quality of life. I don't want any adverse events if possible. So I prefer to take the minimum of treatment that you suggest. So I think in this case, it's also important to show the patient the options and talk about adverse events that are to be expected. We never know whether they come, of course. And then to check out with the patient how much safety she needs in order to not to be...
balance the risk of relapse and toxicity. That's important. So coming back to the response, we had 41 response, so 10% decided for tamoxifen alone, 22% tamoxifen plus ovarian function suppression, 34% aromatase inhibitor ovarian function suppression, 20% abemaciclib, and 15% olaparib if she had BRCA1 mutation.
What would you advise, Evandro?
What I would advise, if she had a mutation, I would go for endocrine therapy and olaparib because it improves invasive disease-free survival, distant disease-free survival, and overall survival. If not, I would try to give endocrine therapy with abemaciclib because she has 1 positive lymph node. She had a grade 3 tumor, which is in the indication of today's treatment. Okay. Moving on for the... Thank you, this. Let's move to the next session. So I would like to invite Stephanie, who is online, to start to present the part of Erika and her part as well. So Stephanie, welcome to the studio.
Thank you for having me. So I am going to be starting by presenting Dr. Hamilton's slides, so I want to honor the work that she put into presenting these. So Dr. Hamilton started by really focusing on the question about, at the beginning of this case, was this patient appropriate for chemotherapy or not? And I think that takes us all the way back to the early days of TAILOR-X and RX-Sponder. And so I'll just walk through that data to refresh everybody's memory. Of course, we all remember that TAILOR-X accrued patients from 2006 through 2010 and pre-registered patients so that patients were enrolled at the time of their Oncotype DX testing. So we ended up with Arm A, which were patients with Oncotype DX scores of less than 10, Arm B and C, which were the primary treatment arms or experimental arms of randomized to chemo alone, chemo plus endocrine therapy or endocrine therapy alone. And then Arm D were patients with high risk recurrence scores of greater than 25, 26 to 100. And those patients all received endocrine therapy plus chemotherapy. And that primary focus group ended up including 6,711 patients that were equally randomized and was presented and published in the New England Journal of Medicine in 2018. And what we saw first for that very low risk, the group with scores of less than 10, was that they had a fantastic outcome. Their risk of recurrence at 5 years was very, very low, with a distant recurrence-free survival rate of 99.3% at 5 years, which is really exceptional. And this actually resulted in the AJCC restaging to incorporate Oncotype recurrence score to take patients with an Oncotype recurrence score of less than 10 and restage them all as stage 1A. And then the primary treatment result patients, there really was no benefit for patients with those intermediate scores from 11 to 25 of adding chemotherapy. So that became the magic number for all of us, where if your score was less than 25, there was no benefit from chemotherapy. But as you can see in this graphic from Dr. Sperano's original presentation at ASCO that Dr. Hamilton included, that curve was very beautifully overlaid with nearly overlapping blue and yellow curves, almost creating a green curve for patients over the age of 50. But there was quite a bit more chaos for patients under the age of 50. And when they broke that down for the premenopausal patients, what we saw was that as patients got younger, the benefit of chemotherapy was quite a bit higher as the score got farther and farther to that 25 magic threshold, so that patients under the age of 50 with a recurrent score of 21 to 25 had as much as a 6.5% benefit of chemotherapy. There's been lots of controversy about how much of this benefit was actually mediated by the ovarian function suppressive effects of chemotherapy. But if we all remember back to the TEXT trial, there was some evidence that the patients that most benefited from ovarian function suppression were the patients that had also had chemotherapy. So it's not clear if it's a 1 + 1 = 3 effect or if they're actually the same effect. And I think that that's maybe one of the great unanswered questions still in breast medical oncology. But again, the TAILOR-X trial was all lymph node negative breast cancers. So moving to the lymph node positive cohort, which more closely aligns with our patient case today, in premenopausal patients, again, there was an obvious benefit for the addition of chemotherapy with a 5-year improvement in invasive disease-free survival for the addition of chemotherapy of 5.2%. Whereas in postmenopausal patients, there was no statistically significant difference in invasive disease-free survival in the endocrine therapy arm versus the chemotherapy plus endocrine therapy arm, again, with nearly overlapping curves where the red and the blue curves almost become purple, unlike in the premenopausal curve where they nicely stay separated there. As I sat and listened to this presentation, some of the things that I keyed in on were actually in her earlier presentation. So one of the things that I think is interesting that maybe we don't talk about enough is how we think about our risks of developing breast cancer. We've all known that women are at their highest individual risk of developing breast cancer during pregnancy, that it's a very high risk time for any individual woman. and that pregnancy-associated breast cancer globally has a poor prognosis for many reasons, including delays in diagnosis, but also some biologic mechanisms that result in a worse outcome. There was a study that was recently published in JAMA in 2022 that looked at a population of patients from Utah because they have really comprehensive record keeping of family histories in Utah. It is a very homogeneous population, which is a criticism of this data set. But it looked at the breast cancer diagnosis within 5 years of childbirth independently and saw that it was associated with a 1.5-fold elevated risk of developing breast cancer metastasis and a higher risk of breast cancer specific death with a hazard ratio of 1.5. And I think that this is just really notable and may change the way that we think about pregnancy-associated breast cancer, because it may not just be those patients that's had a pregnancy within the last year, but it may be patients like our patient who's had a pregnancy in the last 2 or 3, or in this study from Utah, 5 years. I do know that this study is now being repeated in a more heterogeneous population than just those patients in Utah. And so I look forward for additional follow-up in this study. Next up in our patient is that, she expressed a clear intent to have more children. She had stopped contraception and was planning to have a second child. She only has 1 child. And so we need to consider, as we talk about options for her, is whether or not we can do anything to help her preserve fertility. We should, prior to initiate chemotherapy, discuss fertility preservation options for her. At least in the United States, unfortunately, a lot of fertility preservation choices are just financially out of reach for our patients. There's lots of great support services, grants, nonprofits that can help patients. Most health systems and cancer centers have great social work services that can serve as great resources. And I'm sure that's true internationally as well. But Matteo Lambertini, one of our OncoAlert faculty, has done great work looking at the role of gonadotropin-releasing hormone agonists administered concurrently with chemotherapy as a tool to, by suppressing the ovaries, helping to protect the ovaries for future fertility in premenopausal patients. And he presented that analysis in 2017 at San Antonio and published in JCO in 2018, and showed that patients that got GnRH agonists ultimately had a better were more likely to be able to achieve pregnancies in the future and did not necessarily have a worse breast cancer specific outcome, even when considering hormone receptor positive breast cancers. So I do think that this is something that we could consider in our patient to help protect her ovarian function. Next is that at ASCO 2023, we did see the results of the EBCTCG meta-analysis that looked at what ovarian function suppression means to our patients in terms of their long-term outcome. And we did see that patients that are offered ovarian function suppression have a decreased risk of disease recurrence, with a 15-year gain in reduced risk of recurrence of 9.8% for patients that are known to be premenopausal after chemotherapy. And so I think that even with a great response to neoadjuvant chemotherapy, this patient is likely to get significant benefit from ovarian function suppression. And that is perhaps highest in patients under the age of 45, and our patient was 32. So she may be a patient that gets an even more substantial benefit with a 15-year gain of 10.9%. Importantly, from that EBCTG meta-analysis that Dr. Gray presented was this middle graphic looking at death without recurrence that really saw no increased mortality for ovarian function suppression. Because I think one of the things that we historically have worried about is the risk of ovarian function suppression in potentially putting our patients at risk for cardiovascular outcomes or other secondary causes of mortality. And we really saw no difference in the patients that were offered ovarian function suppression. Last, as we consider her fertility, is Dr. Ann Partridge and other OncoAlert faculty's positive trial presented at San Antonio in 2022. And the positive study randomized patients that were premenopausal and had been on endocrine therapy for at least 18 months, but no more than 30 months, to a 2-year interruption of adjuvant endocrine therapy. Ultimately, patients were very similar to our patient, on average about 37 years old. Of 75% had not had a prior pregnancy. They had been sort of on a mix of options for endocrine therapy. Most had had prior chemotherapy. And ultimately, what we saw was no difference in patients' breast cancer outcome as compared to historical controls when they had this 2-year drug interruption to allow for them to proceed with chemotherapy. And those that were able to become pregnant had great pregnancy outcomes. With 74% of the patients were able to achieve at least one pregnancy, and 64% of all women, 85% of those who became pregnant were able to have at least one live birth, with overall healthy offspring outcomes for the babies born on the positive study. So I do think that there's lots of good news that we can offer our patient, both in terms of improving her outcome with ovarian function suppression and hopefully giving her options for fertility preservation now and in the future as she considers her options as she moves through her cancer treatment. So I think we have another poll question, and I don't know if we want to pass this question back to the audience. So regarding her future attempts at pregnancy during adjuvant endocrine therapy, which of the following is true? Pregnancy can be attempted on adjuvant PARP inhibitors or adjuvant CDK4/6 inhibitors. The positive trial allowed patients as much time as patients needed for conception, pregnancy, and breastfeeding. Patients enrolled in the positive trial were not allowed to pursue support from reproductive endocrinology. The 2 years patients interrupted endocrine therapy for conception, pregnancy, and breastfeeding during the positive trial counted toward the total 5 to 10 years of adjuvant therapy recommended to each patient. And secondary endpoints for positive showed that 74% had at least pregnancy, 86% of those who became pregnant had at least one live birth. I can't see the poll results, so hopefully, Evandro, you can take it back over and see those.
Yes. So thank you very much, Stephanie. So people can start to vote for you here in the studio. Use the QR code for you. At home you have it on your screen, so you can choose between among options 1 to 5. Let's see if the answers are coming. Yes, they are coming slowly. I think you discussed something very important about the positive trial. That's very good news for patients that they can become pregnant during the endocrine therapy. They have to stop the endocrine therapy, have a washout period, and then attempt to a pregnancy. This is very important because we see patients, young patients, they always question this. Which are the chances that I can have babies afterwards? I think this is important. I think we face on a daily clinic base. I think as patients is a very important thing if you can constitute family as well.
Absolutely. This was such an important trial for the whole community and all the young women. The thing, I'm not sure whether it was, there was a consent about breastfeeding.
If they had,
whether that's okay.
Yeah, they could.
After this washout period, and how long exactly the washout period should be.
I don't.
So
I think. Go ahead.
In the positive trial, you were allowed 2 years off your endocrine therapy to do anything you needed to do. So if that included just attempts at pregnancy, actual conception, and childbearing, breastfeeding. But when your 2 years were up, you were encouraged to resume endocrine therapy. That 2 years did not keep the clock counting on your 5 to 10 years of adjuvant endocrine therapy. So then you had to pick up where you had left off. If you had done 2 years, you still had 3 left, for example. But you could keep, if you got pregnant your first day and had a baby 9 months later, then you got all the rest of the time to nurse. And so there was lots of flexibility. And if patients hadn't achieved a pregnancy by 1 year, they were encouraged to seek fertility preservation and support from a reproductive endocrinologist.
So this was definitely one of the best news, I think, for young women in the last time. And when I had breast cancer 20 years ago, in the beginning of my 30s, I wish I had this data.
Yeah, very important.
So,
data.
very important.
Very important for patients. So let's see what people said here. 5% said that you could attempt pregnancy on adjuvant PARP inhibitors and adjuvant CDK4/6 inhibitors. I advise not to. This is not recommended. Patients should not be pregnant while on these treatments. 15% said the positive trial allowed patients as much time as patients need for conceptual pregnancy and breastfeeding, which is actually not correct. Stephanie just mentioned they had a 2 years period to attempt the pregnancy, have the baby, and if they want to breastfeed afterwards, they could. 3% said patients enrolled in the positive trial were not allowed to pursue support from reproductive endocrinology, which is not correct as well, so patients could do it. 28% of the patients, they said that the 2 years patient interrupted endocrine therapy for conception, pregnancy, and breastfeeding during positive counted towards the total 5 to 10 years adjuvant therapy duration, which Stephanie just mentioned. It did not count. They have to start the clock over. So if they use 3 years, then you stop for 2 years, then they're going to go back for the 3 years to complete the total endocrine duration. And 48% of the respondents, they said the secondary endpoints for positive showed 74% had at least one pregnancy, and 86% of those who became pregnancy had at least one live birth, which is correct. So it's very good news. So
and what is your experience with patients? How compliant are patients to the recommendation? How do you see in the clinic?
You mean to go back to?
To go back? Or
Yes, exactly.
Yeah. So, in the positive trial, about 70%, 74% of the patients, they went back on endocrine therapy. Yeah. Okay. So I think...
There was on trial, so maybe real-world data could be different, or do you have this impression? Or
I don't have much experience with patients become pregnant during the endocrine therapy, but I think you have to discuss, before you interrupt the endocrine therapy, you have to discuss risk of relapse. Yeah. You're going to interrupt, but you have to resume the endocrine therapy afterwards. I think this is very important. Everything is going to be dependent on the risk of relapse and the time of the patient. So you have to discuss.
And probably women in that type of situation, I assume they would be very compliant to the suggestion of the clinician. So I would assume a very positive compliant to the recommendation.
Yeah, I hope so too.
Yeah, well, I think it's kind of a situation when they feel that they are stopping something that really benefit them for a reason, a strong reason. And then, the cases that I have, they are really wanting to go back to the endocrine therapy because, it's like finishing their treatment. Yeah.
Yeah, but indeed, the oncologist needs to pursue this and discuss with the patients and should stimulate them to go back.
That's crucial.
Yeah, that's crucial.
And talk very clear about the risk of
relapse. Yeah, that's important. So, thank you very much, Stephanie. I think you can continue optimizing endocrine therapy for us.
I'm sorry, I forgot I had more slides from Erica.
No problem.
So moving forward, Dr. Hamilton has more slides on optimizing endocrine therapy. And we're going to move in and talk a little bit about the CDK4/6 inhibitors. So starting with Monarch-E. Monarch-E, as I'm sure you all know, is a trial that randomized patients with high-risk, hormone receptor positive, HER2 negative, node positive, early stage breast cancer. The patient did include premenopausal and postmenopausal patients, women or men. Most had received prior neo or adjuvant chemotherapy, and they were all within 16 months of surgery. and randomized them to either abemaciclib 150 milligrams twice a day plus endocrine therapy or endocrine therapy alone. 5,600 women were randomized. Patients were randomized in 2 cohorts. Cohort 1 included patients with 4 or more positive lymph nodes or 1 to 3 positive lymph nodes plus an additional high-risk feature, which included either grade 3 tumor biology or a tumor size greater than 5 centimeters. Cohort 2 was defined as high-risk disease based on Ki-67, including 1 to 3 positive axillary lymph nodes and a Ki-67 of over 20% with a grade 1 or 2 tumor and a tumor size of less than 5 centimeters. So basically, your high-risk feature there was the Ki-67 being elevated. We have follow-up now to 6 years of therapy, and we'll go through that. So characteristics of patients, it was, again, mostly women, which is maybe not surprising for a breast cancer trial. A nice mix of patients over the age of 75, about 15% of patients were over the age of 65, but a lot of very young patients, 85% young women. Estrogen receptor positive disease obviously was the majority. Most was progesterone receptor positive with about 10% progesterone receptor negative. And a fair amount of premenopausal patients, 43% of patients were premenopausal. And when you see the mix of disease, large portions of these patients had stage 3 disease with 36% stage 3A or stage 3C. And when we compare invasive disease-free survival and distant recurrence-free survival in the left and right there, you can see that those curves are continuing to separate across time, which is very reassuring because we know that as patients only took the abemaciclib for 2 years, that by these later time points, everyone on study was off the abemaciclib. So we are seeing a durable benefit of having been on the CDK4/6 inhibitor. Now with a improvement in invasive disease-free survival of 6.4% and distant recurrence-free survival of 5.9% at 48 months for the addition of abemaciclib to adjuvant endocrine therapy. The monarchy efficacy for distant recurrence-free survival in the intention to treat population, again, really shows a very significant outcome with a hazard ratio of 0.65, which again is improving over time. The 2-year DRFS was 2.5%, improving to 4.1% at 3 years and 5.9% at 4 years. And I think we should be getting updates soon as this data matures and matures. And I think that this is really reassuring and tells the story that taking these medicines for that high-risk population has a meaningful, durable benefit for patients in their risk of distant recurrence over time. Safety profile is, what we've come to expect with abemaciclib. Of course, there is a significant rate of diarrhea, but most is grade 1 or grade 2 with a small risk of grade 3 diarrhea, as well as fatigue, arthralgias, which is matched due to the aromatase inhibitor, and neutropenia. But we all, I think, are familiar with how dose modifications can reduce the risk of developing those. At ASCO 2023, Dr. Hamilton had presented the outcome of invasive disease-free survival according to relative dose intensity. And she shared at this in this presentation that patients that had dose reductions had a stable benefit. Their invasive disease-free survival remained the same. I think that that is really reassuring for our patients that have side effects and need dose reductions, that they are still getting the same benefit from the addition of abemaciclib. That may not quite be the same that everybody's okay starting at a lower dose. This may be, our body's way of telling us that adverse event means that we're okay on a lower dose as opposed to everybody's okay on a lower dose. We can't necessarily use one to mean the other, but definitely means that patients with dose reductions can feel comfortable knowing that the dose reduction is appropriate for them. So, next question. What factor does not define a patient with hormone receptor positive early breast cancer as high risk for adjuvant abemaciclib? A, 4 or more positive lymph nodes. B, node positive and grade 3. C, node positive and tumor greater than 5 centimeters. D, age less than 50.
Yeah. Just pay attention that the question is does not. So the answers are coming here. So how you define a high-risk patient, Roberto, as a pathologist?
I will talk about that in a minute in my presentation, because that's exactly a crucial issue.
Mm-hmm. Let's wait for that. So the answers are coming. For a patient perspective, how you say a high-risk patient, what is important for you to consider the risk of a relapse?
I think what is important to make sure that it's not only age-related. Mm-hmm. And I think it was a long time like we thought younger patients per se have a higher risk. And I think the more we talk about the pathologists, are included in everything. So the more we understand it's not only a matter of age.
Yeah, very important message. So we have here 20% of patients said that for a more positive node is not. I have to say that according to Monarchy, they are considered high risk for more positive lymph nodes, and clinically they are. Node positive and grade 3, 17%. Again, in the Monarchy, 1 to 3 positive lymph nodes in tumors with grade 3 or tumors greater than at least 5 centimeters, they are also high risk. And age, 55% of patients said that respondents said that the age is not a risk factor.
How many percent?
55. So, yeah, I think you need to, Roberto, that's your job to tell people what is considered a high risk, because there is a lot of discrepancy here.
I'll do my best.
Okay, thank you. So, thank you very much, Stephanie. Moving on, we go to Dr. Roberto Salgado to talk about high risk. So, Stephanie already started the discussion. We finished the first part with this question on high risk, and now you're going to tell us.
So, I'm the pathologist. So, I'm the other guy in the category other of specialties.
The guy we patients never see.
The guy that never sees patients, yeah. But it's important to realize that all the variables that we described, there is always a patient behind. So let's have a look. So this is invasive ductal adenocarcinoma. ER and PR very high, HER2 1+. We can discuss about HER2 low and these crazy definitions. Grade 3, Ki67 very high, mitotic activity 20. TILs 30%, and we can discuss on the TILs later on. Lymphovascular tumor invasion, many of them. And high-grade DCIS. Defined as luminal B. However, what are the issues that we will discuss in the next 10 minutes and later on is what actually is a luminal B patient. If you ask 5 clinicians, you get 5 different answers, and actually there is not a single consensus on what defines a luminal B patient. So we will dive into this in a minute. And the second question is about gene expression profiles used in clinical practice, which is actually the brave new world in clinical science. Very expensive, very different, and do they give the same type of information? So that's what we're going to discuss a little bit. And how does a clinician select an assay? One uses MammaPrint, the other uses EndoPredict, the other one uses Oncotype. Why is this difference there? And are their criteria actually uniformly applied and used worldwide or globally or even within a certain country to decide when to test? So let's have a look very briefly on those items. Clinically high risk, well, from my perspective, there is not a single definition which is widely accepted as a clinically high-risk patient. We saw the definition in MORAC. We saw the definition in other phase 3 trials, the Keynote 756, which we will see later this year, has defined clinically high-risk glomerular patient in another way. And the Oncotype DX as one of the gene expression profiles, actually in the TAILOR-X and the ERICSPON, there is no risk classification at all. Only the MINGDAT trial used the concept clinically high risk, and not the other trials. And we mentioned Ki67, 60%, yet none of the phase 3 trials, which are based on gene expression, used Ki67. So when we think about this concept of evidence-based medicine, we use actually criteria in our daily practice which are not replicated or used in the phase 3 trials where we based our decisions on. So I told you, brave new world. Let's have a look more in detail. Ki67. The MONARCH used 20%. And for a brief period of time, it was a companion diagnostic by the FDA. A working group of breast pathologists have for 7 years worked on trying to find a method to score Ki67 in a reliable manner. And we did find a method to score Ki67. But we did find in the high range, in the low range, we're actually very good, but in the middle range, it's actually not so good. But once again, what is actually the best cutoff to use Ki67? And there is not a single consensus in a single international expert group that define this is actually the best way to define high-risk based on Ki67. Why? Because it's a continuous variable. And the outcome of Ki67 and outcome is continuous. So the cutoff is always a discussion and will always remain a discussion. So maybe we should stop using cutoffs for Ki67. Nevertheless, in some resource-poor countries, which actually are the large majority in this world, they don't have the finances to reimburse very expensive gene expression profiles, of which the costs are normally between 2,000 and 3,000 euros. Here in Belgium, we have developed a system where we reimburse 1,500 euros irrespective of the gene expression profile as long as it has the highest level of evidence. Let's go to the other extreme. What is a clinically low-risk patient? This is maybe a bit more easier. A small tumor, lymph node negative, ER positive, HER2 negative, grade 1, low Ki67. I think most centers, most pathologists, most clinicians would consider this is a low risk. But in the high risk, it's the brave new world. And does the assay matter? Well, we will see in a minute, the same patient tested with different assays, you get different risk classifications. But nevertheless, in the premenopausal patients, you always see the same benefit. In TAILOR-X, MINGDAT, and ERICSPONDER, comparing MammaPrint with TAILOR-X and ERICSPONDER. This is one of my favorite studies, developed by John Bartlett at the University of Edinburgh. He has tested the same patient population using 3 different gene expression profiles. And look at the green bar. The green bar is the low risk. So a patient tested with Oncotype might be low risk, it might be high risk using MammaPrint. So what do? And Procinia, it's somewhere in the middle. Is this confusing or not? I don't think it is, but there is a condition to this. Another example, done by pathologists. 1, 2, 3, 4, 5, 6 different gene expression profiles. Look at the distribution between high risk, low risk. Half of them have intermediate risk and half of them doesn't have intermediate risk. In some countries, there are 5 of these reimbursed. How should a clinician choose which assay he should use? We can discuss on this. So the patient got chemotherapy. It's high risk, luminal B, and high TILs. We do know that patients with high TILs in the luminal space have a good PCR, but it doesn't impact event-free survival. So why is it important? And we can discuss this later on. The residual disease setting is actually a topic which is emerging worldwide because of the so-called post-neoadjuvant trials, in which the treatment after surgery is determined on the characteristics of the residual tumor left. And you have PCR versus no PCR, which is binary. But now we know, thanks to work of Fraser-Simons, that the risk of recurrence and the event-free survival after surgery is a continuous variable based on a combination of the size of the residual tumor and the size of the residual tumor in the lymph nodes. So this patient had a little bit tumor left, RCB1, which is nearly the same as a pathological complete remission, nearly the same. And the lymph node found isolated tumor cells. I think there were 4 of them. And why is this important? Because isolated tumor cells is not a topic in the residual disease setting. So even if the pathologist finds 4 tumor cells, or even 1, it is considered as residual disease and not as isolated tumor cells, as it would be in the untreated setting with a lymph node, for example. And grading Ki67 is not available because there is no tumor left. But why did we do Ki67? Well, because at the Jules Bordet we just presented, and it's in press, a meta-analysis showing that the more proliferation you have in the cancer cells after treatment, the worse the outcome. And with persisting extensive lymphovascular tumor invasion and DCIS. What you see here, to your right, it's the survival curves based on a pooled analysis of Fraser-Simons, more than 5,000 patients, showing that actually a PCR and a little bit of tumor left actually has the same outcome for luminal disease. So who cares about these isolated tumor cells if we know, based on a pooled analysis, that the outcome is exactly the same? And this question relates to how we should use prognostic variables, how we should use gene expression profiles, and how we should use lymphovascular tumor invasion. Because we tend to think that we should use these variables as a binary variable. You treat or you don't treat based on a low genomic risk or a high genomic risk. So the question is, of all the prognostic variables that we have in breast cancer, mitotic activity, vessel invasion, grade, tumor size, liver, how many of those have the highest level of evidence, meaning have been tested in prospectively randomized trials? And you can vote.
Yeah, please start voting. The votes are coming. Thank you very much, Roberto. It's very important to define the risk and what is left after the neoadjuvant therapies. This is really important because today you can personalize treatment afterwards, like you mentioned, some subtypes and not no. So people are still voting.
You leave us with a lot of questions.
Good. Yeah. That's why I'm here. Yeah. That's why they put me in the other category. Huh? Oh.
Yeah.
Sorry.
Yeah. Yes, because the genomic assays has been used so much right now.
Yeah.
It's like, unless the low risk that you mentioned, the other ones, I mean, there is always a window.
There is a misuse of gene expression profile in some countries where it's widely available. Very low-risk patients are tested to give or not give chemotherapy. They would never receive chemotherapy because they are so low risk, but they are using, so a misuse of testing. So let's see the answers. You're going to tell us at the end.
Tell the answer, yeah.
29% said no. 29, sorry. 41% said all of them. Ula. And then 90% said just one, which is the correct answer.
The answer is
in
just one.
1 second.
Just one. Gene expression profiles. It's the only prognostic variable tested in a prospective setting. All the other prognostic variables are based on retrospective analysis. And the message I wanted to bring is that none of these prognostic variables should be used in a binary manner. They should all be used together, including gene expression profiles. So actually, it doesn't matter how many gene expression profiles you have. The clinician needs to know about the assay, the risk profile, and combine it with the clinical picture of the patient.
Yeah.
And that's the main message.
Let's discuss this during the discussion panel. So we discuss the use and misuse, overuse of a gene expression profile. So thank you, Roberto. So it's my pleasure now to have Dr. Isabel Rubio to talk about the surgeon's perspective in the treatment of breast cancer patients.
Thank you. So we know that there are many advantages from the neoadjuvant treatments, but related to what has changed in terms of surgery after neoadjuvant treatment is that it has helped us to do more conservative surgeries in the breast, and in the last 5 to 10 years, we've seen that we can also spare some axillary surgery and do less lymphadenectomies that are clearly have secondary effects. So these are some of the data of the PCR depending on the molecular subtypes. And as you can see here, and probably the ones that has changed more in terms of increased PCR are those where with HER2-positive breast cancer or triple negative, where there has been an increased use of the immunotherapy and the double blockade. But still in the luminal B like this patient, probably the PCR rates are between 15 to 20, 25%. So what is important when deciding about the type of surgery that we are doing after neoadjuvant treatment, I think it's important that we need to mark not only the breast, but also the axilla, if there is a positive node, like in the case that we had before. And I think that even, and probably the pathologist, we can discuss that, even if the patient is having a mastectomy, we should mark, because if she had a very good response, the pathologist will have a nightmare trying to find where the tumor was really. So mark everybody who is going under neoadjuvant treatment. The volume of excision, of course, need to be based on the post-neoadjuvant treatment, because, you know, there is no point of excising the whole footprint that we had before. There are some issues that we need to account, and is like we need to leave some clips, mainly for the radiation therapists. So I think that when we are planning and doing the surgery, we need to take into account the rest of specialists that are going to look at to give treatment or look at the specimen. There is also important the radiologic methods that we use for diagnostic, and it's good to use it the same thing before surgery to decide on the type of surgery. Of course, you know, oncologic outcomes goes first, but cosmetic outcomes need also to be taken into consideration. And there has been many debates of why, if there is an improvement in PCR, breast conservative surgery has not improved so much. But it's true that in those high-risk patients with HER2-positive or triple-negative breast cancer, I think that we are a little bit worried about, you know, if the tumor is big, you know, probably they have more recurrences if we do a breast conservative surgery. But I think nowadays, the breast conservative surgery rates in this group of patients or high-risk tumors are increased as much as probably the PCR. So down there. But also it's important when considering the neoadjuvant treatment in terms of the surgical standpoint is that we don't really need a breast PCR to do conservative surgery. And we can see from this very nice study that even in those patients who do not have a PCR in the breast, we can still up to 70% do a breast conservative surgery. So in some patients like the luminal B who has lower rates of PCR, we can still do breast conservative surgery if they have a reduction in the volume of the tumor. There is also an issue with the microcalcifications, whether we need to excise all of them or we can just leave it after the neoadjuvant treatment. We know that they don't disappear. So when we look into the mammogram, and we have seen the case in this patient, we still see the microcalcification, even though the MRI has a complete radiological response. But as you can see in this study, even in those tumors HER2 positive where the microcalcifications get the highest response and turn out to convert to negative, only 50% of the times they are negative. And also it becomes a problem in the follow-up if we leave microcalcifications there, because it will be very difficult to do the follow-up. So as far as now, the standard is just to excise them. What about the axilla? Well, you can see here from randomized studies that the rate of conversion from positive axilla to negative has increased over the years with the improvement in the systemic treatments. And nowadays that made us think that we can do less axillary surgery. And these are some studies that were randomized looking into those patients with a clinically positive axilla and the false negative rate of the sentinel lymph node biopsy. Of course, the three studies, even though they were done in different continents, achieve almost the same results, meaning that there is a way standardized of doing the sentinel lymph node biopsy in those patients who has neoadjuvant treatments. And if we do some indications like, using a dual tracer, marking the nodes, and also, excising more than 2 nodes, then, the rates of false negative results going lower, because we were a little bit worried that this increase in the false negative rate of the sentinel node could imply that there is a risk of having more axillary recurrences, but this is not the case, really. Even though we keep looking into how can we reduce more and more that false negative result of the sentinel node, because it's true that if we have a false negative, that patient is probably missing the opportunity to have a post-neoadjuvant treatment that can improve her prognosis. So we just start marking the nodes, and you can see here in this table with different types, every group has a different way of doing it. We use the intraoperative ultrasound, some of them use magnetic seed, radioactive seed, but the truth is that with the combination of marking the node and doing the sentinel lymph node biopsy, the rates from a meta-analysis has shown that it's below 5%, and this is something that it's a really good number. So at the end, another question is whether do we need to perform an axillary lymph node dissection in those patients who has a positive sentinel node. And nowadays, the standard is to complete an axillary lymph node dissection because, as you can see here, in all these studies, the rates of having non-sentinel lymph nodes positive after a positive sentinel node can be as high as 60%. Of course, in those cases with an isolated tumor cell in the sentinel node, there is not many cases, but still, you can leave tumor behind the axilla, and there is no data now that we can prove that leaving positive nodes in the axilla in the neoadjuvant setting is the same as the adjuvant setting. So nowadays, the axillary lymph node dissection is still a standard here. Of course, in those patients with a clinically positive axilla who convert to negative, and we only do the sentinel lymph node biopsy with this requirement that I mentioned before, the follow-up and the prognosis is really good as with no different with those patients who had an axillary lymph node dissection. And you have some studies here with follow-up of 10 years with axillary recurrences that are very low and no significant differences. So where are we going with these patients with a positive axilla? Well, there are many studies looking into the addition of radiation therapy instead of axillary lymph node dissection, or in those patients where we can spare any radiation therapy and any axillary lymph node dissection, but we will have to wait for the results of all these trials a little bit more of the years. So in conclusion, I think that it's important that we assess the patient at the beginning of the treatment just to make sure what is the upfront surgery they could have, and then after the neoadjuvant treatment, an assessment again to decide on what is the treatment that they need. We know that we can reduce the axillary lymphadenectomy in those patients with a clinically positive axilla who undergo a conversion to negative with the sentinel lymph node biopsy and the targeted axillary dissection. It's true that we need to accept the radiological, using the same type of radiological imaging before and after the treatment. And of course, it's already proven that breast conservative surgery in those patients who are ineligible at the starting the neoadjuvant treatment and become eligible has a good prognosis and do not have more recurrences than those ones who has breast conservative surgery. So I think that the improvement in the systemic treatment has improved the way we do surgery, and it has helped to lower the morbidity from the surgical treatments, keeping the quality of life of the patients and the oncological outcomes. And this is the question that we have for the audience. So is it true that breast conservative surgery after neoadjuvant treatment, it is only indicated when there is a radiological complete imaging? Then you can help me with the rest of the
Of course, we are pathologists, we're here to help. So the second statement is, it is not recommended in HER2 positive and triple negative disease, as there is an increase in recurrences. And the third option is, it should not be done in patients with an indication of mastectomy prior to neoadjuvant treatment. And the fourth option is, around 40 to 50% of those patients ineligible for breast conservative surgery may become eligible after neoadjuvant treatment.
Okay. Thank you very much, Dr. Volte. In the meantime, we're going to address one question that is coming here is regarding the having residual disease, if there is any difference in the adjuvant setting if residual disease occurs in triple negative breast cancer. What's the impact of residual disease in triple negative, first as pathologists?
Well, it's actually exactly the same as a luminal disease, and it's exactly the same as in HER2 positive disease. But there is one big difference. When we analyze the immune environment in triple negative breast cancer, we can stratify the RCB2 category, so not the extremes. So when you have the RCB3, meaning practically all tumor is left, and the PCR RCB1, actually no tumor is left. In that context, the immune environment is negligible. But in the RCB2 category, only in the triple negative breast cancer setting, if you have high amount of immune cells, you can distinguish that group between the excellent outcome and the worst outcome, and this is not observed in HER2 positive disease and luminal disease. So this is important because these so-called post-neoadjuvant trials may include the immune environment when stratifying patients in triple negative, and this should not be the case in luminal.
Now we have two positive disease. Yeah, that's a very important message. And for the triple negative, it makes a difference because you can adapt treatment, like you mentioned, for the others. So for patients with BRCA1 mutation and or one or two mutations and residual disease, triple negative, they can receive olaparib for 1 year. And for those patients without the mutation, they can receive capecitabine for 6 to 8 cycles. So you can adapt the treatment. So let's see what people said here. 3% said that it's not recommended near HER2 positive and triple negative, as this is an increase in the recurrence. And 3% said it should not be done in patients with an indication of mastectomy prior to neoadjuvant treatment, and 91% said around 40 to 50% of those patients ineligible for breast conservative surgery may become eligible for breast conservative surgery after neoadjuvant. Your answer?
Yes. So the answer is the last one, because one of the main problems with the neoadjuvant treatments and the surgery is that patients were not assessed before neoadjuvant treatments of what type of surgery they will have. And there was always this thing about, what is the size that when you can do breast conservative surgery, that it's an old story, now it's not about size, it's about response. And nowadays we can use oncoplastic techniques. So many patients who 10 years ago just need a mastectomy, now we can perform oncoplastic techniques, and in a high percentage of them, we can still do breast conservative surgery. So I think it's important that we need to assess we need to see the whole picture when we decide about the surgery.
Yeah. So I'm going to address another question that came here. Is just a questioning what is the duration of neoadjuvant therapy if patient needs breast conservative surgery? How many cycles you give before you decide to operate the patient?
So we give all the chemotherapy up front. I think that this sandwich thing that they did many, like 20 years ago, nowadays what we want is to achieve the highest response, and the highest response is achieved with the whole regimen up front.
Yeah, okay. So let's move to the radiation oncologist.
My pleasure.
Thank you very much, Pierfrancesco.
My pleasure. Thank you. It's really a pleasure to be here. So my task of today will be to display you the role of radiation therapy in a setting of a patient that underwent primary systemic therapy. So what is the problem, the issue for radiation oncology while facing and trying to offer treatment to a patient that underwent primary systemic therapy? The main issue is that we are lacking pathological information to be able to properly tailor the post-operative radiation therapy treatment. We do have pathology, of course, but we have somehow a pathology that has been modified by the primary systemic therapy. So the data that we rely on are data that come from the past. So we have this information, but we should somehow try to adapt our indication to the new sequences of treatment. So this is very important. And what do we know from the past? We know that radiation therapy is effective after breast conserving surgery in reducing the locoregional relapse, in reducing the cancer-related death. And this is true in terms of relative reduction of risk for all the risk category, but the absolute reduction in risk depends on the baseline risk of the patient. So there's a chance for stratification of the risk of the patient, and also to address the strength of the indication for radiotherapy. In a setting of post-mastectomy radiotherapy, we also know that post-mastectomy radiotherapy is effective in reducing locoregional relapse, cancer-related mortality, and in improving overall survival. But what is the problem? The problem is that these data are dated and come from a long time ago, and now we live a new era where we have a screening, we have very effective surgical methods, we have the issue of stage migration, we have very effective systemic therapy. So we kind of need to update the information that we have from the past to try to overlap with the new setting that we have. And then we have the data on regional nodal irradiation. Regional nodal irradiation can be offered to patients after both breast conservative surgery and mastectomy. Regional nodal irradiation is, again, very effective in reducing any recurrence, in reducing breast cancer mortality, and in improving overall survival. This is true for high-risk patients, so patients with more than 4 positive lymph nodes. It's also true in the category 1 to 3 lymph nodes, but maybe it's not that true for patients that after primary systemic therapy or after surgery have complete response in the nodes. And also this is very true for new trials, so trials that use very effective and modern radiotherapy technique, so doesn't increase the burden and the toxicity for patient, and it's probably less true for older trials that use outdated technique. So we have this data. Radiotherapy is effective after primary systemic, after breast conservative surgery, after mastectomy, and also in the setting of regional nodal irradiation. But now, after the introduction of primary systemic therapy, we know that somehow the pattern of failure of our patient and the likelihood for our patient to develop a locoregional recurrence is a bit different. We have some settings where the locoregional recurrence risk is small. For example, depending on patient characteristics, such as age, depending on the clinical stage at presentation of the disease, but also depending on the response that we have from primary systemic therapy. But if you look at the guidelines for radiation oncology are very conservative. Almost all the guidelines still state treat the patient regardless of the response of the tumor to primary systemic therapy. And why is that? Why we do that? Because if you look at the data, and we have data of patients treated with neoadjuvant chemotherapy without radiation, we see that for patients that have larger tumor involvement at baseline of axillary lymph node, young age, we still have an excess of relapse without radiation therapy, and even in patients that turns PN0 after primary systemic therapy. So that's why one of the reasons that we are a bit conservative in this, and maybe this is all trial, but even in larger, even if retrospective trial, disadvantage of adding radiation therapy after primary systemic therapy, even in patient with a complete response, is still there. So what do? We normally try to combine the clinical data that we have at disease presentation, the clinical stage, the age of the patient, the presence of lymphovascular invasion, the grading, but also we try to combine this with the information that we have with the response to primary systemic therapy, and we try to find our own algorithm in the clinical decision-making process to offer or to not offer, or how to offer, if offer, the radiation to our patients. So what we do normally now is that for clinical node-negative patient undergoing primary systemic therapy, if undergoing a breast conservative surgery, we tend to treat the breast. We don't treat if the patient undergo a mastectomy. We have a category intermediate risk patient and plus patient that turns into pathological complete response after primary systemic therapy. This is a little bit more doubtful category. We need more risk factor. We need the grading, the lymphovascular invasion to tailor our treatment. For patient that doesn't achieve a pathological complete response, we tend to treat. And for patients that tend to have a baseline locally advanced tumor, we tend to treat regardless of the pathological complete response. We are waiting for result of randomized prospective trial that will help us in deciding properly how to offer and when to offer radiation to our patient. RTOG trial B51 is a trial that will tell us whether to treat or not patient who achieve a pathological complete response in the node after primary systemic therapy. The Alliance trial will tell us whether to treat or not and how to treat with radiation or axillary lymph node dissection those with residual disease in the nodes after primary systemic therapy. And the ATNEC trial will tell us how to better tailor the radiotherapy to the axilla for patients achieving a pathological complete response or not achieving a pathological complete response after primary systemic therapy. But the good news is that we have data there, good quality data, prospective data, not a randomized controlled trial, but a prospective clinical registry that gives us good information and the possibility to stratify the indication to radiation therapy based on the response to primary systemic therapy. And this is a trial from the Netherlands, the RAPChem trial, which depending on the entity of the residual disease of pathological complete response in the nodes, personalize the indication and the way we deliver radiation therapy to our patient. So basically, in the end, and to conclude, to me, in my opinion, radiation therapy remains a standard of care in breast cancer patients after primary systemic therapy, even today. But we have to consider that a certain degree of treatment personalization and modulation is possible, and we need to consider patient-related factors and tumor-related factors in the clinical decision-making process. But we also need to take into account the harm of the patient. For example, giving post-mastectomy radiotherapy in a reconstructed patient in terms of possible complication is very different than giving radiation therapy to a patient that received breast-conserving surgery. And of course, we will need to wait for the result of phase 3 randomized trial to have level 1 evidence that will help us in better tailor our treatment and our indication. So thank you very much. This was the last one. I think we still have, hopefully, a question, which is, would you offer the patient that we just described, that we talk about, post-operative radiation therapy? Yes, but only to the breast. Yes, with comprehensive nodal irradiation, so undissected axilla or axilla, if the patient doesn't receive axillary lymph node dissection as our patient, level 3 and 4, or comprehensive nodal irradiation, including also the internal mammary nodes. Or would you offer post-operative radiation therapy? No, I wouldn't offer post-operative radiation therapy.
Okay, thank you very much. Starting vote. While people voting, I want to go back to you, Isabel, because there was a question. Isn't a form of therapeutic escalation to perform axillary dissection in patients with micrometastasis in the sentinel lymph node after chemotherapy? Some of them would not have had dissection with surgery up front, notably the luminals.
So the question is, in those patients who have a micromet in the sentinel node after
neoadjuvant therapy,
that they have positive nodes to begin with.
Yeah.
Is there anything that you don't do apart besides an axillary lymph node dissection? That's the question.
Yeah, that's the question. Are you not over-treating your patients? That's the question.
Well, the thing is that if you want to apply evidence-based, there is no really studies that look into patients with a positive sentinel node with micromets and no axillary lymph node dissection. What is the prognosis? So, I mean, you cannot say that it's over-treatment if you don't have data to support that, you know. Of course, I think that when we are talking about this, sometimes you need to individualize a little bit. So not all the patients are the same. And sometimes, you know, you need to discuss with the patient. So let me go back. Sometimes it's better to wait for the final result of the pathology instead of doing an axillary lymph node dissection while the surgery, because sometimes you need to look into the whole picture. See the preference of the patient also after discussing things. And I can tell you that sometimes with the micromets, because, you know, it's difficult to detect them, and I don't want to go into the pathologist field, but sometimes intraoperatively it's difficult to detect micromets after the neoadjuvant setting, so you just leave it for discuss with the patient. And in some cases, you know, there is an agreement of not doing anything. You know, if the patient has, for example, a complete response in the breast, she's not very high risk patient. You have more than one, so you have one micromet, and then, you know, have probably another 2 sentinel nodes negative. So I think, you know, it can be individualized in some cases, but the standard is axillary lymph node dissection.
Okay, coming back to your question, Pierfrancesco. So 4% said yes, only to the breasts.
Yeah.
33% said yes to the breast and local regional lymph nodes. 63% said yes to the breast and local regional lymph node, including the internal mammary nodes, option C. No one said no.
Okay, that's good. That's reassuring. So it's a young patient with high-risk breast cancer who has residual tumor somehow after primary systemic therapy. Maybe this is debatable, but I wouldn't feel like so sure to consider this as an absolute complete pathological response. So yes or no, the answer will be yes. I would definitely irradiate the patient. Just also because she received breast conservative surgery, so at least she would need radiation to the breast. But then probably given the baseline risk factors and the not complete response, I would try to intensify the treatment by including in the volumes the regional node irradiation. And so option 2 and 3 are reasonable, I would say. This is somehow country dependent and physician dependent, whether to include or not the internal mammary node. Some countries are very convinced into the benefit of including internal mammary nodes, some are not. My personal practice would be number 3, so I would definitely include also the internal mammary nodes in the. So I would agree with the audience,
Okay.
with the participants.
Thank you very much. So now, taking the hook of Isabel, we're gonna go to the patients. So we are very patient-centered decision making. So we're gonna go to you, Eva, and I believe that Tanja is online. Just to confirm.
Yes, hello. Yes, hello.
Yes. Hi, Tanja.
Hello, can you hear me?
Can you hear us?
Yes, I can
We cannot hear you.
Mm-hmm.
Can you try again, please? Yes.
Yeah. Can you hear me?
Yes.
Now?
Now, perfect. Thank you very much
Hello.
for joining us tonight. So we are coming to discuss the multidisciplinary approach of a breast cancer patient. It is very important to have a patient's perspective. So we have Eva and we have you here with us today to give your perspective. So.
Yeah. It's okay, Tanja, I start. So we haven't prepared any slides because about communication we can talk. Mm-hmm. We don't need to show slides. So the latest development have shown some in the adjuvant setting for all tumor types and intensified adjuvant therapies. So it's always a question about how do you communicate a high risk of recurrence. Uh-huh. And what I see in what I hear from patients is that they still often hear after surgery or after neoadjuvant therapy and surgery, you're cancer free or you're cured and all kind of things. And this is something I really have a problem with because I think you have to be honest and you have to say what you know and what you don't know. Mm-hmm. Now, first of all, nobody knows whether there is still cancer. I mean, cancer-free is a word that should not be in a serious conversation between physician and patient. And then the risk of recurrence. Of course, it's nice to tell a patient, well, you know, you're cancer-free and you're cured and she will go home with a good feeling. But I always tell physicians it's not about making her happy. It's about preparing her what might come and talk about adjuvant treatment. Like if you recommend to have an intensified therapy, either with immunotherapy or with CDK4/6 or with in the triple positive setting, there's also an option. So then you have to talk about the risk of recurrence, but also about the additional treatment that you would suggest, which benefit are to be expected, which may be adverse events, but also what do you know? Like how long was the time in the study that patients were being monitored? Mm. Like is it really long enough or are there questions open? Or like, for example, immunotherapy in early disease. Like, I think there's still a perception that for patients that this is some kind of really, you know, kind of mild therapy. And I think you have to talk about that there might be even adverse events that come later, much later, because patients need to be prepared that whatever comes after immunotherapy, even after months or years, it might be connected to therapy. And in the endocrine tumors, and that's what our case was and what we talk here, I always struggle with the 10 years, that 10-year numbers. And now in these adjuvant new trials, we have like much less even time until the first data were presented. And it's important data, but I think it's also important to communicate to patients that there's no long-term data yet. And this is the same, I think, for positive. And Tanja and me were very much engaged in all this topic about young women pregnancy, because both of us had our cancer diagnosis very early. But still, I think it's important to be honest and say we don't have long-term data. And so it's a lot about honesty when you talk about risk reduction, about what can you do, which additional therapies should you give. It's always, the basis is to be honest, even if it's not nice for patients. But having cancer is not nice anyway. And there are many bad news. So it's just maybe additional bad news, but we will cope with it. But only when we have honest information, we can take our decisions. And I think from the first diagnosis, it's important to say which ways you have, and to leave the option open that there might be a longer therapy even after surgery. So patients are prepared and not suddenly, oh, now we discovered that you have a high risk, when patients thought they are done after surgery, and then come back and say, but now you have a high risk and now we have to do this. So I think from the beginning to show options, to talk about all options and then be honest. This is what I'm sometimes missing.
Yeah, I think this is very important, honesty, and discuss. The thing with the neoadjuvant treatment, we don't know what's going to happen to the tumor. So, and then what we find in the surgery after Roberto is going to find afterwards, and this is going to dictate what we are going to do in the adjuvant. So we need to give it a clear picture for the patient so she can know what to do afterwards. Not that comes as a surprise, like you said. That's very important.
I'm sure Tanja can add to what I said. Or
Yeah, so thank you, Eva. I can just maybe second all that you said, but I would just like to summarize all the speakers that we heard today. So this is a very, very plastic example how it looks for a patient. So you go through physical exam, all the diagnostic procedures, through, if you have neoadjuvant treatments, probably twice through pathology, then through chemo, surgery, and radiation therapy. But we have to know that this is all about the patient, and all the time we have to have the patient in front of us. I think that Isabel pointed out very well how to explain this, which type of surgery is the most appropriate to the patient. Eva also mentioned that once patient has all the information in front of her, it's easier to make a decision. I wouldn't say that everybody don't like that you are healed, you are cancer-free. Still, a lot of patients want to hear that. But maybe patients like Eva and me are more aware of all the risks and recurrences, and we are maybe more realistic, or I don't know how to say that. But I made some points during your discussions and presentations. If I may add here also about the positive trial, which is probably really one of the most important trials that young women were waiting for such a long time. And what Stephanie just showed us, I have this honor to be part of steering committee of this trial, and I'm really looking forward what this longer follow-ups will bring. And I would just like to point out that even women who discontinue the hormonal treatment are still followed up, that we will be able to see what's happening with them, and that more than 10% of women included in the positive trial had more than one child, which is also very important, that it's not just limited, okay, you can get pregnant once and go back to the hormonal treatment. I think that this is also very important, not just for women without children before the diagnosis, but also with women that already has children. Usually we see this, oh, you already have a child, so this is not a topic of the discussion, but this is really not the case. We see how successful treatments today are. So women survive more than 10, 15, 20 years, and keeping this option of fertility is very important. And as Fatima Cardozo always like to point out also for metastatic or de novo metastatic patients, it's very important to inform them about the fertility preservation. And just one point that we are very aiming for, what Eva just said, that long-term follow-ups are very important. 5 years, 10 years, is really not enough. But luckily we have EBCTCG, Oxford group that is doing a meta-analysis on this. And we have some data from text and soft trial, and I hope that also from newer trials we will get this data for patients to be easier for them to decide which treatment they can choose. And once we are well informed, also patients get more and more compliant. During the talk today, we also heard the questions: how compliant are women to the therapies? Well, some questionnaires or some surveys show the very, very different results. But it's very clear that women that are very well informed and aware of potential side effects or adverse events that can happen are even more compliant. So this is also very important for doctors to know, and especially for young women like this patient in today's cases, is also a thing of her future. Well, nowhere in between we didn't see actually what's going to happen to her after she finished the treatment. We saw what's her profession, but also these personal preferences, not just of having another baby or two, but also future plan for work is very important for young patient, and to be aware which adverse and long-term side effects she can expect, not just from the systemic therapies, but also from bigger surgeries, why this conservative surgeries are better in this case, and of course, locally regional treatment with radiation therapy. So all this together is something that patients need to have before, we have to have before we make a very good decision for ourselves.
That's very important.
That's it for now.
And I fully agree with you. I think long-term follow-up in clinical trials is very important. Assess also fertility preservation is very important because, like you mentioned, we are giving immune checkpoint inhibitors for patients with triple negative. They are quite young patients. We don't know the effect in the ovarian function. We don't know how it is going to impact fertility on those patients. And this is not addressed in the trials. This should be carefully think in the moment that they design the trials.
Of not communicated to patients.
Exactly. So
yeah, sorry, just a comment on what Eva said, that I think it's probably not a problem of being honest with the patients, because I think that doctors usually are honest with the problem. It's a problem of communication. So we haven't learned how to communicate. So we learn everything, but we didn't learn how to communicate. And sometimes that's the problem, the lack of knowledge of how to communicate with the patients. And I think this is something that it should be taken into account when training in the medical school, and and also it's difficult sometimes to communicate risks, because risk is something that it can be absolute, it can be relative. Yeah. The way a patient or any one of us think about when they tell you the risk, it's very difficult. So sometimes it's easy to make a comparison between risk of daily life and risk. So you can put up the risk what it is. It's.
I think it's a very good point. Communication is crucial. What helps me and risk communication of the risk is very complex and complicated. What helps me normally is try to avoid qualitative terms a little bit, a lot, but try to use more quantitative. I know numbers might be difficult to handle, but I'm confident that most of the patient will be able to handle. And I think it's the right of the patient to weight the number. A specific risk of recurrence, 5%, a specific risk of side effects, 10%. It's the right of the patient to prioritize what is important. It's more important the 5% or the 10%. And so you can have a fruitful communication with the patient, and probably also a good therapeutic decision with the patient if you use numbers. So that's what I think in my clinical practice. I use it a lot, and I have good good feeling about this.
Yeah, I
don't know
think
what
this
you
is
think.
something they understand. But if you talk about relative
Yes.
percentage, this is difficult.
It's difficult for patients.
So then absolute numbers is much easier to
Yeah.
understand.
Yeah, absolutely.
Or maybe some graphics if you have or whatever. But about you're right. Maybe nobody means not to be honest. And but doctors tell me yes, but I want her to be positive when she goes out. So yeah, I say you're cancer free. I say, but when you say we couldn't find any cancer cells, however, we don't know. So so it's still good news.
Yeah, yeah,
But it's honest.
yeah.
In this case, sometimes it's more appropriate to use that there is no evidence of the disease.
Yeah.
So currently, is no evidence of
no
the
evidence
disease.
of disease, I think, should be an appropriate term that should fit both sides.
Yeah.
In the interest of time, I think you're going to move to the case. Then you can discuss some case. So I'm going to start with this case that is Iris. She's 63 years old. She was diagnosed with metastatic triple-negative breast cancer. If you look into her history, she's postmenopausal, she's 63, she has no relevant family history of breast cancer or ovarian cancer. She had a genetic testing that showed no germline BRCA1 or 2 pathogenic variants. She has no relevant comorbidities, good health. She has a very good performance status. And her medical history started 3.5 years ago when she was diagnosed with early triple-negative breast cancer. That was a clinical T2 N0M0. So at that moment, she received neoadjuvant anthracycline taxane chemotherapy. She was operated, she had mastectomy with sentinel lymph node biopsy. She had margins free, lymphovascular invasion was not present. She was a grade 2, she had a grade 2 tumor. She had no pathologic complete response, so she had residual disease still, which was IPT2N0. So she was offered 6 cycles of post-neoadjuvant capecitabine based on the CREATE-X trial. And she was okay, but 9 months ago, she had a CT scan, and that CT scan, chest and abdomen, showed 3 liver lesions. She had a biopsy of one of the lesions, and that biopsy showed a relapse of breast cancer, which was confirmed to be ER negative, PR negative, HER2 1+, grade 2. She also was tested for the PD-L1 status, and she had a CPS of 12. The IC was 0. So she was put correctly in the treatment with pembrolizumab and chemotherapy, which she received for 9 months. She had the best response as partial response. And today she comes back to the appointment with a new CT scans. And unfortunately, the CT scan shows progression of liver metastasis. So then my question to you, to summarize, she had a triple-negative 3.5 years ago, neoadjuvant chemotherapy, anthracycline, taxane, post-neoadjuvant capecitabine. 9 months ago, she had metastatic breast cancer, confirmed triple-negative in liver biopsy. PD-L1 positive, she received pembrolizumab and chemotherapy for 9 months, and now she progresses in liver. What would be the optimal treatment as second line for this patient? Would it be sacituzumab govitecan? Would it be trastuzumab deruxtecan? Would it be capecitabine? Would it be vinorelbine? Would it be anthracycline taxane chemotherapy or eribulin? Please vote now. I think this is a very complex case and happens quite often, unfortunately. We see patients relapse some years ago, particularly with residual disease, and you already addressed the risk of residual disease in these patients.
Yeah. And if I
Yes,
comment very briefly on the metastasis and the PD-L1 score. We do know that metastasis of the same patient, of the same tumor type, have different immune environments. Mm-hmm. So the liver, for example, is notoriously known to have low immune cells, as the skin, contrary to, for example, the lung. Sorry. So it is not unusual to have an IC score of 0, because IC scores cause the immune cells.
Yeah.
So it's not unusual to have progression after immunotherapy, because immunotherapy needs immune cells. So if the liver metastases don't have immune cells, immunotherapy will not work. So we know, based on a lot of series, is that if you have a patient with liver metastasis or skin metastasis or lung metastasis, and if you want to take the biopsy, which would give the patient the best option to give immunotherapy, biopsy the lung and not the liver, even if it's more convenient, clinically speaking, for the patient or the skin. Because now we know that those biopsy sites will have low amount of immune cells and will probably be negative in terms for PD-L1. So I think in this case, it's not unexpected that it's progressive under immunotherapy because there are no immune cells in liver metastasis. Irrespective of the subtype, triple negative, HER2 positive, luminal disease, even if they have high TILs in the primary tumor, they get into the liver and the immune system just doesn't get there. And we still don't know why.
Yeah, it has been demonstrated that it depends on the site of biopsy. They have different
so clinically speaking, if this patient would have lung metastasis and liver metastasis, biopsy the lung. And not the liver.
Yeah, but sometimes it's not so easy to biopsy.
I know.
Ideally, you should biopsy the lung, but sometimes the location doesn't allow and the risks.
Because I think that when you decide on biopsy, you biopsy the site that it's easier
more accessible.
And if I can add, if I'm allowed to add, in this particular case, even if the CPS would be negative and the primary tumor would be positive, you could give PD-L1. PD-L1 inhibition. Why? Because we do know that the immune system goes down in a metastatic setting. And if you give chemotherapy, it goes even more down. And we do know, due to the dynamics of the immune system, is that if you have high amount of immune cells in the primary tumor, those patients will also respond to immunotherapy, even if they develop metastasis many years later, due to the systemic nature of the immune system. So if you have to decide on giving a patient immunotherapy and you can't biopsy for whatever reason, or if you only have liver metastasis and it's negative, and you still want to give immunotherapy, ask your pathologist to go to the primary, score the TILs. That's a biased assessment, because it will be PD-L1 positive if you have high TILs.
Yeah.
And the patient could get immunotherapy even if the primary tumor has high immune cells.
Yeah, that's a good point. Let's see what people voted. So 51% voted for sacituzumab govitecan, 29% for trastuzumab deruxtecan, 3% capecitabine, no one vinorelbine, 6% anthracycline taxane chemotherapy, and 11% ribulin. So I'm going to take the opportunity that Stephanie is online with us. What is your take on that, Stephanie, in terms of systemic therapy as second line for this triple negative breast cancer patient?
What did the audience say? I couldn't hear your answers.
So the question is, the patient had a triple negative metastatic breast cancer.
Oh, no, I heard the case. What did the audience answer?
They said 21%, 50%, sacituzumab govitecan, 28% trastuzumab deruxtecan.
Okay.
And then we had very few with ribulin, 11%, 6% anthracycline base, and 6% capecitabine. So what's your take on that?
I think my short answer is I agree with the audience. That's a complicated area of controversy right now. Obviously the data is there for sacituzumab govitecan in this setting. Sacituzumab is approved for patients that have been treated with 2 prior lines of therapy, and that can include adjuvant or neoadjuvant. So this patient had adjuvant therapy with anthracycline and a taxane, which counts as 1, arguably 2 lines of therapy, and now has progressed on first-line metastatic therapy. So they clearly would have met eligibility for ASCENT. In the ASCENT trial, 488 patients with metastatic triple-negative refractory breast cancer were enrolled and eligible. So it presents very clear randomized phase 3 data for metastatic triple-negative breast cancer benefiting from a TROP2 directed antibody drug conjugate with sacituzumab govitecan. The counter to that is that we have the Destiny Breast 04 trial using trastuzumab deruxtecan for patients with HER2 low expression. This patient, I believe, does have HER2 1+ on their biopsy, so would also be eligible for Destiny Breast 04. But Destiny Breast 04 was originally a hormone receptor positive trial. 88% of the patients enrolled in Destiny Breast 04 were hormone receptor positive. 11% were what we would traditionally have called triple negative or ER/PR negative, HER2 low, like our patient in this case. And so only 63 patients were like our patient. Only half of that 63 got the trastuzumab deruxtecan. And so we don't have that magical p-value because it wasn't statistically weighted to tell us what those triple negative patients really did with trastuzumab deruxtecan. Now, the population report, which is in the supplement, was in the podium presentation at ASCO, shows that those patients did well. We have no reason to think that they wouldn't do well. Ultimately, I think both of those medicines are going to be medicines that I reach for this patient. And so some of it would be a little bit of decision-making for my patient. Trastuzumab deruxtecan is once every 3 weeks. Sacituzumab govitecan is day 1, day 8, so a little bit more often in the office. Side effect profile is quite different for the two drugs, but both have very real side effects. And so I do think that there's an opportunity to engage in shared decision-making. But I think that choosing sacituzumab govitecan or trastuzumab deruxtecan are both reasonable choices. I think the weight of evidence is probably a little stronger with sacituzumab govitecan.
Yeah, I agree with the audience and with you. The strongest evidence is sacituzumab govitecan as second line in this case. You can still use trastuzumab deruxtecan afterward because she has HER2 low. Let's move to the second case. This is a young patient, Lucy. She's 39 years old. She was diagnosed with luminal B breast cancer, clinical T2N1M0, and she started feeling something in the right axilla some months ago. So she has no relevant medical conditions. She had a genetic testing before because she has a positive family history for breast cancer, and she has a pathogenic germline BRCA1 and 2 mutation. She had a stage CT2N1. It was a biopsy showing invasive ductal carcinoma, NST, grade 3, ER 9%, PR 30%, HER2 0, and Ki67 30%. So she had a workup before. She had a breast MRI. She marked the tumor, like Isabel mentioned. That's very important to mark the tumor. And she received a new adjuvant chemotherapy with dose-dense EC every 2 weeks and dose-dense paclitaxel every 2 weeks. She had a new breast MRI after the neoadjuvant treatment, and she had a partial response. There was still 19 millimeter tumor, and there was a lymph node still in the axilla that was stable. 3 weeks later, she went to breast conservative surgery with reconstructive techniques and lymph node axillary dissection. So the pathology report shows a 22 millimeter tumor, grade 3, invasive carcinoma, ER 9%, PR 30%, HER2 is still 0, and Ki is 67, 30%. There is the presence of a lymphovascular invasion. There is no perineural invasion. The margins are free, and she has 1 micrometastasis and 1 macrometastasis. So she has 2 positive lymph nodes out of 11. She was YP2 N1. So she was discussed in the multidisciplinary board, and the discussion was post-operative radiotherapy and then systemic therapy. And so then comes the question to you in terms of systemic therapy. What should this patient receive as adjuvant systemic therapy? Should it be tamoxifen for 5 years? Should it be ovarian function suppression plus aromatase inhibitor 5 years followed by tamoxifen for 5 years? Ovarian function suppression 5 years plus tamoxifen to complete 10 years. Ovarian function suppression plus aromatase inhibitor for 5 years combined with abemaciclib for 2 years, knowing that endocrine therapy can be extended longer than 5 years. ovarian function suppression plus tamoxifen 5 years combined with abemaciclib for 2 years, again, endocrine therapy can be extended, or ovarian function suppression plus AI 5 years combined with olaparib for 1 year, again, endocrine therapy can be extended. So what would be the preference of people in the audience? Please vote.
She has a pathogenic mutation. She's a BRCA1 mutation carrier.
BRCA2 mutation, pathogenic, yeah. So let's see what people is voting for the moment.
So she's
Yes.
lucky that this has been tested, because this is still in ER-positive tumors. I think it's still not being tested enough.
It's not being tested enough, but she had a strong familial history. That's why she was
Yeah,
tested.
she was,
Yeah.
How old was she?
She was 39.
39, so...
Yeah. So people are still voting. There is one question here, meanwhile people are voting. What would be the optimal duration of capecitabine, adjuvant capecitabine in triple negative? Should it be 8 cycles that you give, 6 to 8 cycles, or should it be 1 year as was published in the past for patients with residual disease? Any comment? Anyone want to comment?
You are the medical oncologist.
Yeah, no one. Okay, I'll comment. I think you have more data for the 6 to 8 cycles. I think is well tolerated. We have some toxicity with hand-foot syndrome, diarrhea, but it still is short than 1 year. I think I still is the preferred option today.
In the clinical practice, at least in my institution, they don't use 1 year.
No, nobody.
Really demanding, right?
Yeah, 1 year is quite a long treatment, and you don't see so much benefits like you see for 6 to 8 years that we increase the dose. So let's see what people voted here. So no one would give tamoxifen 5 years. 7% would give ovarian function suppression and AI for 5 years for tamoxifen. 3% ovarian function suppression 5 years and tamoxifen 10 years. 24% ovarian function suppression AI and abemaciclib. 10% ovarian function suppression tamoxifen and abemaciclib. And 55% ovarian function suppression AI and olaparib for 1 year. I'll start to comment on that, and then if Stephanie wants to join. So I think that the ovarian function suppression with AI 5 years and olaparib should be the best option for this patient. She has still a lot of disease. She has 2 positive lymph nodes. She has a 22 millimeters tumor still, so she has a high risk of recurrence. So combine ovarian function suppression and aromatase inhibitors for me would be the best. Start 5 years, but then you can discuss the longer duration of treatment. And olaparib for 1 year in the Olympia trial, it shows that improves invasive disease-free survival, distant disease-free survival, and also overall survival in patients with residual disease, triple negative or ER positive, that have BRCA1 or 2 mutation. So I think she really fits the criteria for the clinical trial.
And then in this patient, because she's a BRCA2 and 39, maybe, we can start discussing the bilateral salpingo-forectomy, instead of ovarian suppression. Probably that will be the ovarian suppression best method, in the patient. Yeah.
Yeah, I think that's an important discussion, because using ovarian function suppression for 5 years, if she has an indication of discussing ovarectomy, I think that's the best option. So she doesn't need to have injection every time. Yeah. Stephanie, do you have any comment on this?
Yeah, I mean, what I'll say is that, this is a case just straight out of St. Gallen's as well. The high-risk residual disease in a BRCA2 mutation carrier, and how do you decide about CDK4/6 inhibitors versus PARP inhibitors and sequencing therapy. And I think the St. Gallen's consensus, and also my practice and opinion, is that PARP inhibitor first, followed by a CDK4/6 inhibitor. She would actually be a candidate for the upcoming adjuvant wider trial, which is a confirmatory study for Natalie, which we haven't really talked about, but is looking at ribociclib for early stage, high risk, hormone receptor positive breast cancer, just like we saw the Monarch E data be positive with abemaciclib, ribociclib has now presented their early data showing that ribociclib also improves distant recurrence-free survival and invasive disease-free survival. But ribociclib was given at a lower starting dose, 400 milligrams, and ribociclib was given for 3 years. So their first report is after a shorter interval of follow-up where most patients are still on the drug. So in order to see that longer duration of follow-up and that separation of the curve, we're going to need longer follow-up on the NATALY trial in order for it to perhaps garner practice change or approval across all of our different practice locations. In the meanwhile, there is a phase 3B, so a follow-up study planned called WIDER that will use the same eligibility criteria with some slightly wider, hence the name, nuance, including allowing patients to enroll longer after surgery. And one of the goals of that is to allow for patients to do a year of PARP inhibitor and then still be eligible for accrual. And so hopefully that trial will give us a first look at what happens in patients in this exact clinical scenario that do a year of a PARP inhibitor and then go on to take the CDK4/6 inhibitor. Of course, NATALY, the ribociclib data did include some N0 patients, so also had some slightly lower anatomic risk patients.
Okay, thank you very much. Let's move to our last case. In this case, Rose. She's younger, 35 years old, and she was in a follow-up visit, and she presented with stage 2 dyspnea, and she experienced these symptoms for the past 2 months. She also had chest pain. Let's see what is her history. She's premenopausal, she has no relevant comorbidity, she has a performance status 1, and the medical history is 18 months ago she had a stage 2 early breast cancer that was a CT3N0M0. The biology was an invasive ductal carcinoma, grade 3, Ki67 40%, ER 100%, PGR 10%, ER2 positive 3+. She received the neoadjuvant sequence chemotherapy and dual anti-HER2 blockade with pertuzumab trastuzumab. She was operated, she had a lumpectomy sentinel node dissection. She had a pathological complete response. She received maintenance with trastuzumab pertuzumab every 3 weeks for 14 cycles, which was stopped 3 months ago for completion of the treatment, and she is receiving endocrine therapy with aromatase inhibitor and ovarian function suppression. In the clinical examination, she had suspicion of bilateral pleural effusion. She had a PET-CT scan that shows bilateral pulmonary metastasis with bilateral pleural effusion without lymphangitis, which was associated also with liver metastasis. She also had a liver biopsy that showed invasive ductal carcinoma, ER 100%, PGR 10%, HER2 3+, EKI67 25%. So, just to remind you, she had early breast cancer, HER2 positive, chemotherapy, dual blockade. She completed dual blockade 3 months ago, and now she has liver, pleural, and lung metastasis, which is still HER2 positive. So what would be your recommendation of treatment? Would it be paclitaxel trastuzumab pertuzumab? Would it be TDM1? Would it be trastuzumab deruxtecan? Would it be tucatinib, trastuzumab, and capecitabine? Please vote now. While they are voting, there is a question. How much the difference between immunohistochemistry result on core biopsy and surgical specimen? How much do you see the discordance of?
Well, for most biomarkers, it's pretty concordant. Mm-hmm. So it's extremely rare to have a core biopsy with high ER, for example, and on the surgical specimen low ER. And actually, this is practically the same for most biomarkers, ER, PR, HER2, Ki67, TILs, etc. So the biopsy is mostly representative of the surgical specimen. Now, from the scientific perspective, we might think about, and it's one of my hobbies, about fractals. Why is it that a tumor of 4 centimeters, in terms of heterogeneity of the biomarker, if you take a core of 5 millimeters, you find exactly the same patterns? And I think there is a fractal geometry scientific hypothesis behind it. Because when you see heterogeneity of the biomarker on the core biopsy, you also see heterogeneity on the tumor specimen. So the answer is to the colleague is it is mostly concordant. Not always, but mostly concordant. And there is a fascinating scientific theory behind it. And that's my theory. It's unproven. So maybe it's not true, but
Yeah, if it's done in the same place.
if it's done, yeah.
It's done in the same place, yeah.
That's true.
So the answer, 5% said they would give paclitaxel, trastuzumab, pertuzumab, 9% TDM1, 86% would give trastuzumab deruxtecan, no one would give tucatinib at this moment. So I think in this case, she has progression of disease, short period of pertuzumab, trastuzumab dual blockade, then would be to move to like the second line for HER2 positive, which would be in this moment trastuzumab deruxtecan. There is a trial testing Breast Destiny 03 comparing trastuzumab deruxtecan versus TDM1, and it was superior in terms of progression-free survival and overall survival. So today, trastuzumab deruxtecan took over TDM1. Yeah.
Would like clinical condition eventually play a role in the decision making of the second line therapy? Is it something that you would?
I think it would. Yeah.
You need like to offer a patient that kind of treatment. You need a perfectly fit patient, or this is like.
She has a PS score 1, so I think she should be fit to receive that. So we can start with the treatment and then see whether you need to adapt the doses. Since it's easy to administer every 3 weeks, I think is a very good compromise. With a less good performance state, then you have to discuss more fragile. You have to discuss what you have to do. So yeah. Okay.
And good supportive treatments when you start the therapy.
Yeah, I think that's important. Trastuzumab deruxtecan is not like TDM1 in terms of side effects. You have a little bit more side effects, so you have to give more attention to the patient. You have to really give him medication for nausea, vomiting, because this can happen, which was not common with other anti-HER2s. Alopecia is also something that the patients have experienced that is not so easy for them. I think
what I sometimes see is that with these supportive treatments, many doctors still tend to start with a little bit anti-emesis, for example, and then increase if necessary. I think it's better to start with a maximum and, if possible, decrease, because you don't want to leave patients with this horrible experience of the first treatment, and then so start with the maximum. It doesn't matter whether we get a bit more DEXA or whatever. This is not what makes a difference, but a difference of tox, but it makes a difference
for the patient quality.
For the patient.
Yeah.
So start with the maximum and, if possible, decrease instead of the other way.
The other way around.
It's my suggestion.
Yeah, it is also that the nausea is quite prolonged with TDXD. Yeah, so that's what you see. So I think you had a very good panel discussion, very good faculty tonight, and I think you arrived at the end of this beautiful meeting today. So for people watching us at home and here in the studio, help us to improve our service and increase the quality of our content by completing the evaluation form. After this webinar, you'll be automatically redirected to the evaluation page. Please complete this, answer some questions. If you are here on site, you scan your QR code. We really appreciate your feedback. So I would like to thank the faculty here in the studio and at home, Tanja and Stephanie. I would like also to thank again OncoAlert for organizing this meeting in collaboration with Mirror of Medicine and our sponsors, the Daiichi Sankyo, AstraZeneca, Lilly, and Gilead. And stay up to date with the latest evidence. You can look in the Mirrors of Medicine. You have a lot of cases to help you to make a better decision to your patients. So thank you very much for being here tonight. Thank you very much for attending this meeting, and have a very good evening. Thank you.
Thank you. Thank you very much.